Hello, good afternoon, everybody. Mr. Gale.
Thank you, my Lord. As I indicated earlier, my Lord, this afternoon is going to be a reading of the statement of Dr. Jennifer Burns. The reference is SCI WT 0572000001. She has provided this statement, and as my Lord will see from paragraph 2, she does not wish to give evidence at the public inquiry, but she has agreed that it be read and recorded. And given its significance on a number of points, I took the view that it would be useful for this to be read into the inquiry notes and also to be made public in this way. As my Lord will see, her name is Jennifer Burns. For present purposes, she is 62 years of age. Her address is known to the inquiry. She retired from full-time NHS employment on the 30th of November last year, although she has remained available for a certain amount of locum work over the winter until April of this year. Her academic and professional qualifications are contained in paragraph 4, and paragraphs 5 and 6 summarize her specialist interests, and as my Lord will see, her interests have been largely in geriatric medicine, and in 1995 she was appointed as a consultant geriatrician at Glasgow Royal Infirmary, and she worked there until her until her retirement on the 30th of November of last year. My Lord will see at the bottom of paragraph 7 that she has held a number of roles in the British Geriatrics Society, including as being the chair of the Scottish Council of the Society from 2012 to 2014. And then she was elected as president, first of all as president-elect, from November 2018 to November 2020, and took over as president from November 2020 until finishing the role on 17th November 2022. So for present purposes, my Lord, she was in place as an office bearer of the British Geriatrics Society during the whole of the pandemic. In paragraph 8, she sets out the background of the British Geriatrics Society, and I'll just start reading from there. It's a UK-wide medical society. It represents all 4 home nations with individual councils UK-wide. We have over 4,000 members, and about 10% of them are in Scotland. The Society is a multidisciplinary membership organisation with which healthcare professionals join on a voluntary basis. The majority of consultants specialising in geriatric medicine working in Scotland are BGS members. I'll just use the abbreviation BGS. The BGS has the aim of improving healthcare for older people. It supports its members through education, training, and the provision of guidance to support its members deliver better care. It supports and encourages research. It does policy work to support and spread good practice beyond the members of the Society and to influence national policies and programs for older people's healthcare. Non-members can access many of its key reports. They can attend conferences, access the Society's website, use its reports and tools, and undertake education and training. In geriatric medicine, most of our consultants will work in acute care hospital settings, but some will work across the acute and community care. We recognise that a lot of care of older people is across all specialties and in primary care. The BGS is keen to liaise and support across many different specialist areas, as overall older people are the population group that use health and social care services the most. It has never advised the Scottish Government at any time formally, and it doesn't sit on any Scottish Government-led government boards. Throughout the pandemic, it was meeting with other medical specialties throughout the Royal College of Physicians of London, and this allowed for sharing of experience and helped guide best practice. The senior officers of the Royal Colleges would have meetings with the chief medical officers. In Scotland, the chief medical officer appointed by Scottish Government is supported by a number of deputies and clinical directors to provide advice to the government. During the pandemic, Professor Graham Ellis, who was a consultant geriatrician in Lanarkshire, filled this role. He later became Deputy Chief Medical Officer for the Scottish Government during the pandemic. BGS excuse me, was able to contact and liaise with him informally on issues relating to older people. Paragraph 14 is significant, we suggest, my Lord. BGS were never asked formally to give an input or advice to Scottish Government going forward in a future pandemic. If the Scottish Government wanted to strengthen their team, they could ask us to be part of that. She then deals with communication and guidance. As clinicians, BGS had regular updates and guidance on management of COVID, both from the government and from our health board area, and in our health board area. BGS was focusing on supporting its members, encouraging research and producing guidance in our specialist area. For example, it recognized the impact of COVID in older people, particularly those living in care homes, as likely to be significant. It aimed to augment the guidance for those involved in caring for residents in care homes, both carers, nurses, and medical professionals who might develop COVID. BGS produced a range of recommendations from picking up symptoms and options for treating to proactive planning for what might happen if somebody got COVID. It was recognized that at the start of the pandemic, there was no effective treatment for this new virus. Consideration was given to whether those patients would benefit from hospital care and what we could provide in the care home that might replicate what somebody might get if they were in hospital. Many people who are living in care homes do not want to be hospitalized, and if their care can be provided in a care home, then that is very often the preferred option. BGS suggested that we look at provision of enhanced medical care within care homes. The aim was to support services to be proactive in developing those services. For example, oxygen concentrators to allow safe delivery of oxygen that might not routinely be there, certainly not across the whole of the NHS. Most of Scotland would not automatically have access to that. The BGS guidance on managing COVID in care homes was published, then revised 3 times over the pandemic, and was one of our most downloaded documents. It was available on the BGS website, circulated to its members, and it was entitled Managing the COVID-19 Pandemic in Care Homes for Older People. There are a number of footnotes to Dr. Burns' statement, my Lord, and some of these documents are contained within those footnotes. It was first published in March 2020 and last updated on the 18th of November 2020. There was a lack of peer-reviewed scientific papers on the impact of COVID on older people and care home residents in the first wave, so the understanding of the range of symptoms patients had at onset of the illness was limited. The practitioners were relying on the information they were getting via the media to some extent, about the effect the virus had on people in care homes in Italy. There was a recognition that the virus would have a devastating effect on people in care homes. Practitioners weren't sure what was happening or going to happen in Scotland or in the UK, but excuse me, but we could see that there was a real and significant threat and that older people would be very vulnerable, particularly older people who were living with frailty. Frailty is a distinctive health state relating to the aging process in which multiple body systems gradually lose their inbuilt reserves. Around 10% of people over 65 have frailty, rising to between a quarter and a half of those over 85. Older people living with frailty are at risk of adverse outcomes after even apparently minor challenges to health, such as infection. People living in care homes are likely to have more advanced levels of frailty. And I just pause there, my Lord. I think this morning Mr. Simmons made some reference to frailty, and also when Dr. Croft gave evidence, Your Lordship actually asked him about frailty, so that does give a little more explanation. The BGS wanted to support research into the impact of COVID infection on older adults with frailty. We shared information on multi-centered trials, gathering this data amongst our members, and many teams collaborated to undertake this work across the UK, and the references are given. The published data now confirms the link between higher mortality and morbidity and advancing frailty. She then deals with feedback from members on guidance. We did not have any formal feedback from surveys or other sources on the utility of the guidance, but certainly our impression was that our members were pleased that we had produced the guidance and that there was a gap in what was available in relation to support for care home residents and their healthcare teams. The fact that the guidance was reviewed 3 times was testament to the fact that we were reacting to feedback and from the evolving evidence. As time went by and there were options for different treatments and testing coming in, then we included that in subsequent versions. The guidance remains the most downloaded publication of all time on the BGS website. There is then some guidance for hospital settings. BGS produced a range of tools and templates to support those managing patients in hospitals, in the hospital setting, to augment other guidance. In the hospital setting, in addition to symptoms of cough, breathlessness, fever, it was common for older adults to present with delirium, acute confusion, loss of appetite, falls, or syncope, gastrointestinal symptoms, and deterioration in functions. This was common to other illnesses presenting in older people. It was recognized by clinicians working in acute settings that testing needed to expand to cover atypical presentation, to allow accurate diagnosis and infection control measures. It took some time for this to be implemented as the evidence of this atypical presentation took time to appear. She then deals with the Scottish Government's response to the pandemic. It was challenging to manage this pandemic with limited understanding of the effect of this new virus on the Scottish population. Looking back now, the lack of universal testing and the delay in recognizing the variation of symptoms in older people left older people exposed to underdiagnosis at the early stages of illness. The mortality rate from COVID infection is very age-dependent and higher if you are frailer and have complex comorbidities, as was the case with many hospitalized older people and care home residents. Delay in recognizing this may have challenged measures aimed at infection control. In any future pandemics, we need to identify and plan for those who are most vulnerable to poor outcomes. Age and frailty are two of the main factors identified post-COVID, and people who are being supported in care homes or older people in hospital settings with other health problems exemplify this. Planning should focus on support to minimize the spread of infection and to deliver a high standard of care for those with the infection. It would have almost been impossible to prevent the spread of COVID in care homes because people need care and they are cared for by individuals who had exposure to COVID in the community. The impact on health services. The health service is stretched at the moment, and we are seeing the development of services outside hospital. This is known as hospital at home in Scotland or virtual wards in NHS England. During the pandemic, this was well developed in some health boards such as NHS Lanarkshire and NHS Fife, but not universally available. This allowed people to access additional assessment in homely settings, including support in care homes. It was possible to deliver treatments such as IV fluids, oxygen therapy, and if needed, other treatments that traditionally would have required hospital admission. This is recognized as a useful addition to the health service and has been progressively rolled out over the years of the pandemic. The Care Inspectorate Scotland look at the quality of care to ensure it meets high standards. They provide inspection reports of the care home sector, and where improvement is needed, they support services to make positive changes. This is an important scrutiny mechanism. However, in the fast-moving pandemic, the sector needed additional support to manage infection control and deliver enhanced care for residents. This resulted in more oversight from health boards, both tracking of infection outbreaks and support to roll out, for example, staff and resident testing and ultimately vaccination. These changes need to be supported as people living in care homes benefit from enhanced support from health service teams. In terms of impact on the health service, the NHS and care home sectors have always been stretched. Vacancy rates were always high before COVID, but Dr. Burns suspects that they are even higher now, although she doesn't have any figures on the care home sector. The impact on members of BGS of working through the pandemic was significant. Guidance was changing quickly at the start of the pandemic, and that came with its own challenges. BGS undertook a survey of its members' experience during the first wave of the pandemic in the autumn of 2020, and published the feedback through the Visor report, which again is referenced. The survey asked questions about people's experience of access to viral testing, availability of PPE for staff, and patient movement in hospital settings, as well as impact on individual members. The feedback on the survey reflected the concerns of the individual members. There was a frustration surrounding delays in testing, the quality of the tests, and what level of PPE was available to staff. BGS carried out a second survey in spring 2021 and followed that up as published through the Visor report. BGS provided the inquiry with a copy of our two Visor reports, summarizing the experience in the working environment. And, Lord, I confirm that we have those and have considered them. She then deals with transfer of patients from acute hospitals to care homes. BGS were reviewing the guidance from the governments in England and Scotland on discharge to care homes. BGS recognised that people have a right to be in their home, care home, and if that individual did not have to be in hospital, you would not want them to be in the hospital. Early in the pandemic, BGS noted that in and again, document managing COVID in care homes, that if residents were discharged back to care homes when tested positive for COVID, they should be isolated in their own rooms for 14 days. We also advise that all new or return admissions to a care home setting should be isolated from other residents for 14 days. Later versions of the guidance indicated that testing within 48 hours of hospital discharge was required, and to seek advice from the public health teams on managing previously positive patients. Around mid-April 2020, more routine and asymptomatic testing patients for COVID had been introduced within hospitals. It was clear that patients should be tested before discharge to care homes. The benefit of this approach allowed us to identify if somebody had or did not have COVID, and public health advice was then followed. There remained a risk that individual patients could be incubating COVID and have, at the early stages, a negative test. So isolation of residents for 14 days post-discharge to care homes continued to be supported in our guidance. The medical profession learned during the pandemic. An example of this was the risk of discharging patients from hospitals to care homes without testing. By the 20th of April 2020, patients were being tested to attempt to prevent infectious patients being discharged into care homes in Scotland. We must acknowledge the vulnerability of the care home sector. There would, however, be patients who would test negative and then go back to the care home and still have COVID because that's the nature of the virus. It doesn't always present with a positive test. So the additional advice of suggesting a period of isolation for a resident after discharge to care home was appropriate, and I believe we did get there in Scotland. Access to suitable testing seems to have been the limiting factor in rolling out more universal testing for this situation and for hospital admissions. With regards to testing, Dr. Burns says that she can't comment on any variances across Scotland, but what she can say is that technology was evolving rapidly and the length of time it took to get a result reduced over the first few months, and ultimately we had point-of-care testing. She then deals briefly with impact on acute settings. She says, we didn't have the capacity to do universal testing initially on all hospital admissions. And as she has mentioned previously, not everyone who had COVID showed symptoms, and some had atypical symptoms. So not everyone was tested who were admitted, and that was the reality in most acute hospitals. Some patients had typical symptoms who met criteria for testing, and others did not. The learning in that was very rapid, as she refers to earlier. Older people are major users of hospital services, and they were not universally tested in the beginning. And until we got that type of testing, it wasn't possible to have a true understanding of the impact of the virus on different groups and to organize safer routes through hospitals for them. She is unable to comment on what the delay was for the availability of testing. That would need to be answered by a public health team or a virologist. She then deals with the impact on people living with dementia in care homes. A very high percentage of people living in care homes have dementia, either diagnosed or not formally diagnosed. In a care home, you would normally have a mixture of physical and mental disability to meet the requirement for 24-hour care. Patients with dementia were more likely to suffer delirium if acutely unwell with illnesses such as COVID, leading to a more confused and agitated state, and it can be hard to keep them safe in an environment. Conversely, delirium can cause people to become very sleepy and to stop eating and drinking. This is medically described as hyperactive or hypoactive delirium. A study published in the journal Age and Aging, which followed older patients with COVID admitted to hospital showed that mortality increased independently with both age and increasing frailty. And although delirium was not independently associated with increased mortality, it was linked with prolonged hospital stays and poorer functional recovery. So more survivors needed enhanced care after the illness. The BGS guidance, Coronavirus Managing Delirium in Confined and Suspected Cases, was published in March 2020. It did explore the issues of managing cases of delirium linked to COVID infections. It included guidance on screening of delirium linked to previous SIGN guidelines and provided support for staff on the role of medication. But it also highlighted the challenges of managing physical isolation of infected patients. We understood these difficulties from a range of clinical experiences working with people pre and during COVID who had dementia and delirium. With regards to difficulty accessing resources, the major issue would be increasing staff ratios in wards and care homes to provide more one-to-one care. BGS recognized that those patients dying from COVID were more likely to need high-quality end-of-life care and summarized resources from a range of providers in our resource COVID-19 end-of-life care in older people, again reference. This signposted to NHS England's clinical guide for management of palliative care in hospitals during the coronavirus. That's reference to another document. Clinicians access these resources to guide best practice across hospital and community settings. Our members did feed back to us that they were part of supporting not only patients and residents, but also families of people who were affected during the pandemic, and this was a taxing role for them. She was asked how the clinicians supported care home residents' families. This would be largely about communication on diagnosis, prognosis, and treatments, and this was given remotely in the main. She makes then some comments on rural care homes and hospitals. She doesn't have any information from members regarding rural areas, but she is aware of a new service set up in Forth Valley via networking. There it was developed an acute hospital at-home service for care homes in particular. It was led by a local general practitioner who was supported by geriatricians and palliative care. Forth Valley Health Board would know more about that as they were part of the commissioning organisation. There are workforce shortages in geriatric medicine, which are felt more in rural health board areas. For example, at this point, there was only one geriatrician permanently in Dumfries and Galloway. This limits the reach of the specialist service, so it is harder for them to innovate and deliver care across a whole health board area. She then deals with accessing services across the board. During lockdown, there was obviously a real reduction in face-to-face interactions. Many interventions would normally have been face-to-face, and it was not possible during COVID in the same way as previously. Rehabilitation after illnesses such as broken bones or after falls is known to improve outcomes and quality of life. So some remote advice was offered. It took time to reintroduce this element of face-to-face activity. It has improved steadily, but some services have not resumed due to staffing demands in other more acute areas. This does disadvantage older people who may already have lost ground due to periods of isolation during the pandemic. There was huge innovation in developing remote consultations. I think that it was one of the successes and remains a useful part of what can be offered. She says that she knows a lot of speech and language therapists were able to do a lot more work on phones and on computers, which was previously dependent on the individual being able to use the technology. As geriatricians, we offer acute care, but also outpatient care and day units, where such clinicians would receive interventions from the multidisciplinary team. That stopped for many months as it was not possible, relying as it did on people coming in groups and shared transport. Going forward, more patients now attend with support from family members, but there is some resumption of hospital transport. The BGS records suggest not all services have resumed. The impact of that, she suspects, we do not see when you ask older people. Age UK undertook surveys published in July 2021 looking at the impact of lockdown on older people, and they see more issues with more mobility deteriorating and mental health deteriorating. She says that she does not think that prolonged lockdown had a negative effect on the health and well-being of older people who didn't contract COVID. As we redesign services going forward, we need to make sure that access is good for people with disability and older people. There were delays in accessing some healthcare services and memory clinics, which has led to a backlog now that it is in recovery mode. She was asked what could have been done better until vaccination was successfully introduced. There was a risk of hospital visits, and so risk assessment was required before restarting business as usual. She's not sure what could have been done differently there. It must have been difficult for people who were developing dementia and waiting on a diagnosis, and for their family members supporting them. They might not have been able to access the support that they normally would have got. Alternatives to face-to-face have changed some of the outpatient model of the NHS and how it runs now. Within her specialty, the issues the patients have are not always best met by video consultation. This is particularly true for new patient visits or for conditions that require physical examination. However, it can be suitable for follow-up consultations. She will want to see a new patient face-to-face if she could, but some of her colleagues will use it, particularly if it's in a rural area. It can also give the choice of whether the clinician, as a patient, want to be seen face-to-face or alternatively by video call or phone. Having that option can be more patient-focused, as travel to clinic to see a doctor for perhaps a short consultation if you have a disability can be difficult. Feedback from members in rural areas is particularly positive. It can work as long as it is person-centered and the patient has the options and support to ensure the access to services addresses their needs. She then deals with PPE and testing. There was a lot of variation in the guidance on both testing and PPE required in the first few weeks. Initially, the use of PPE was only in COVID areas, but then it was recommended for all patient interactions, and if some high dependency settings where you were fitted with an FFP3 mask. Obviously, that was difficult for members because of how certain you could be of rapidly changing recommendations. There was concern about the level of protection afforded by the standard PPE in general COVID ward settings, and this was reflected in some of the comments in the Through the Visor survey. As time passed, evidence was collected on this. It is a complex area as other factors such as ventilation of rooms or wards can affect the risk of contracting COVID. When the guidance came out from Scottish Government with what they recommended to be worn, in general, we had no issues accessing it in the acute setting. And by March, at the end of March 2020 in Scotland, we were wearing masks, gloves, aprons with eye protection for close contact with those with confirmed COVID. Hand washing and hygiene were always the cornerstone of our infection control. We adhered to the provisions set out in the guidance of the Scottish Government. The lack of universal testing early on meant that we were not confirming all cases, as some were either asymptomatic or had atypical symptoms. This results in difficulties in infection control and in later diagnosis for some patients who would later deteriorate. As testing became more available, we had other challenges, as some patients, particularly those with dementia or delirium, found the testing difficult to tolerate. Time to test result varied dependent on the type of test and test setting. The introduction of point-of-care testing with immediate results improved this, but often needed follow-up tests to confirm the accuracy. Public health teams will have learned a great deal about testing and should be able to advise future pandemics on the best options to improve outcomes. Nursing staff managed to support patients with testing, showing empathy and compassion with those who lacked capacity to understand the reasons for often multiple testing. She then deals with do not resuscitate orders. While end-of-life care has always been an integral part of care for older people, the acute and rapid changes seen with COVID changed the pace and focus of that care. BGS supports and encourages patient-centered care with sensitive advanced care planning conversations and best interest discussions with patients and their loved ones. One aspect of this is considering the likely benefits and harm from medical treatments such as CPR and communicating this sensitively. We had to acknowledge that this was a virus that we didn't have a treatment for with very high mortality. If you got to a point where your heart or breathing process stopping with advanced COVID infection, then CPR was not going to be successful. These decisions are then documented in medical records as a communication advice to other staff. It is important to explain this to patients and families. BGS guidance on end-of-life care in frailty has resources to support healthcare professionals in managing these often difficult conversations. Understandably, this can be difficult and unexpected for some patients and families. It is so important that concerns are alleviated with good communication and trust in the health professionals providing care. A decision not to undertake CPR should also be part of a plan to describe what treatments are available and might be useful, and these can be documented in records in the form of treatment escalation plans or in anticipatory care planning records. The benefits of having advanced care discussions are to enable a more dignified death with a focus on symptom control and patient wishes. She then goes on to deal with changes to roles and impact on BGS members. Some staff did get moved out of day units or had changes to shift. Extra on-call and ward provisions were required to meet the challenges. We captured some of this experience in our Choose surveys on the membership in 2020, published it through the Visor reports. These reflect the strain on our members. Mortality was high in some wards, and providing care in these settings was very challenging for all our members. There were also positive experiences in that people felt that they were making a difference and pulling together as part of a team. Some of the innovations and technology improved, as did the fast-flowing pace of the evidence and the continuous learning and ability to contribute to research. There were negative and positive comments, but she suspects there's still an impact on our members, and she doesn't have direct evidence of that specifically. The membership itself was mainly frontline NHS staff. They were first-line responders when the demand for the job was at its peak. There was concern for the patients and concern amongst the staff for themselves. There was anxiety about whether they were adequately protected with PPE. They did ask if people had time off or sickness absence, and there was a higher than usual sickness absence rates. There was significant COVID-related illness among staff. This was before vaccines, so some colleagues were very unwell. Some of their colleagues had also died. These anxieties about one's own health, the risk to vulnerable family members, combined with the intense nature of the clinical work, was really taxing. During the first period of COVID, the difficulty was dealing with acutely unwell patients with limited treatment options and high levels of uncertainty. As the pandemic progressed with peaks and troughs, there were positive changes, with research offering some effective treatments and a well-managed vaccination rollout. However, the duration of the pandemic required longer-term resilience to continue and manage the challenges. In relation to training and conferences for BGS members, BGS managed to switch quickly to a virtual model. They continued to offer education to members at virtual conferences and webinars. Some of that depended on staffing levels and access to study leave, but attendances at virtual conferences increased over pre-pandemic levels. This supported continuing professional development, but also allowed some reflection and learning on the pandemic. Access to this was supportive of emotional well-being by shared experiences and networking. She then expresses a personal view. As an individual, she continued in her full-time job in Glasgow Royal Infirmary and was involved at the BGS initially as president-elect and then from November 2020 as president. Work as a clinician meant that she experienced all of the challenges of managing patients in acute hospital care. It was emotionally draining and also important and rewarding to be able to provide care for those vulnerable patients. She was part of a large multidisciplinary team of healthcare professionals and needed to support them in this important work. Her role at BGS also meant that she was involved in meetings and providing resources for the BGS's members, and she was able to attend virtual meetings with the Royal Colleges once a fortnight and network with colleagues in many other disciplines. The next section is on impact of COVID and lockdown on older people. The Age UK survey is interesting, and she doesn't know if Age UK also did something similar. Age Scotland did something similar. But one of the things I captured was that the term vulnerable, which was a blanket term used to apply to older people, is quite a shock for people who are happily living their lives. The report comments on anxiety related to the risks from the virus, resulting in many being afraid to go out and resume previous activities even when restrictions had eased. Having to be isolated from family and close friends had an impact. We know that regular exercise, maintaining physical fitness, social interactions, and a sense of purpose all combine to build resilience and prevent disability. The lockdown affected many older people's ability to undertake these activities, and the longer-term impact of this is likely to be negative for their physical and mental health. The rollout of vaccinations targeted older people and residents in care homes as top priority, and this has been a success in giving enough protection to allow a more normal life to resume. It then deals with restrictions, particularly in the context of end of life. Restrictions on visiting in acute and care home setting were more difficult to manage. It was all a balance of risk. If you had open visiting with no restrictions, there was the potential of the virus being brought into the setting. This might affect not only the individual being visited, but potentially the wider population within the setting. Lord, I'll just pause there. The next paragraph is one that the inquiry team thinks is of significance and bears some relation to what Mr. Simmons said this morning. Care homes are an individual's own home, and as the pandemic eased, restrictions eased in many settings, but were slower to relax for those living in care homes. Social isolation is harmful to care home residents and can result in low mood or cognitive or functional decline. We were restrictive for a lot of the pandemic for reasons that at the time she supported, but on reflection and feedback from members, she considers that these restrictions were too prolonged. Visiting policies should take account of the benefits and risks to the individual resident, the potential risks to the wider care home population, and the current prevalence of COVID in the surrounding community. As testing capacity increased, a rollout of testing for visitors to care homes could be added to the strategy to provide some reassurance. Evidence shows that many residents in care homes are in the last months of their lives, and long periods without a visitor are harmful. Whilst there is a complex balance of rights and responsibilities, campaigns such as John's campaign highlight the importance for the right of people with dementia to be supported by their family carers, and they are campaigning to embed this in law. She does think that is something that needs to be thought about for the future, particularly for those in need of care. Visiting in hospital and care homes was allowed in end-of-life situations, but deciding when somebody is ill enough to warrant a visit was difficult, as patients' conditions can change quickly, and health professionals had to make judgments on this in care home and hospital settings. Sadly, it will be inevitable that some families didn't get the warning in time and missed the chance to visit. There's then a section which I would simply take as read on literature research by BGS and move on to the section on guidance at paragraph 75. We received guidance from the Scottish Government regarding changes, restrictions, PPE, testing, oxygen provision, amongst other things. The government were being advised by scientific advisory groups. We would then receive our guidance from the health boards, but also via professional routes such as the Royal Colleges of Physicians, London, Glasgow and Edinburgh, who ran virtual webinars fortnightly, giving updates on the evidence for treatment options. Professor Adam Gordon was the lead author in the care home guidance, and he sat on the social care group of SAGE in England. BGS care team guidance was circulated to members of BGS in Scotland. The first guidance was published on the 25th of March 2020 and revised and updated after that. She then deals with lessons learned. Just before she completed her term as BGS president in November 2022, BGS published a paper on, quote, lessons learned from COVID, trying to capture what we have learned and highlight priorities for future pandemic preparedness. We have highlighted 10 lessons for the future. And, Lord, just at that point, perhaps I can simply refer to that document. It is footnoted in her statement. And there are, at page 4 of that document, there is a summary of the lessons that she sets out, or that the BGS sets out. There is one that I would particularly refer to, and that is lesson 2. It's in these terms: there is a need to ensure that a balance is achieved between protecting care home residents from a virus that could be fatal for them, and also protecting the human rights of individuals to see their families and loved ones. That's expanded on in the narrative at page 5 of that document. If I could just read briefly from some of that. It follows on from the well-known opinion of the then Secretary of State for Health and Social Care, Matt Hancock, about throwing a protective ring around care homes. And the BGS document says this: rules on visiting in care homes change regularly, with many families and care home operators struggling to keep up with what was allowed and what was not. Many of the restrictions in care homes remained in place long after restrictions were lifted for the rest of society, and many family members became frustrated at not being allowed to visit their loved ones face-to-face, even once both the visitor and the resident were vaccinated. That's a reference to a paper. That particular paper made 5 recommendations for government planning for future pandemics, including the acknowledgement of family visits and the human rights for care home residents and the need for better guidance for care home staff, as well as improved communication with family members. Going back to paragraph 77, Dr. Burns says, if there is another pandemic, it is likely to have a similar impact on older people and those with other vulnerabilities. The full report details these in full, but I would highlight the need to ensure a balance is achieved between protecting care home residents from a virus that could be fatal and also protecting the human rights of individuals to see their families and loved ones. Planning for the response to a pandemic should involve experts on the population most affected by the illness in questions at the earliest possible stage. Services should be available and adequately funded to provide patients with the most appropriate care in the best place for them. For some patients, this will be in hospitals. For others, it may be in their own homes or care homes. Clinical trials must include the populations most at risk and most likely to benefit from the treatments being tested. In the majority of cases, this will include older people. As a society, we need to be more open about talking about death and dying, so preparing for end-of-life care isn't as shocking, particularly if one's own health has been deteriorating and, for example, one needs support in a care home. Opening the conversation ahead of the final days allows individuals to have a chance to express their thoughts and wishes, and for those caring for them to recognize what is important to them. Additionally, NHS and social care workforce planning must ensure that there are enough staff, that all staff have the skills they need to care for the aging population, and that staff are cared for mentally and emotionally and supported to continue to work in these roles. The workforce remains under stress due to the vacancies and shortages and inadequate numbers of staff in training to replace those who retire or leave. She is keen that the inquiry comes out with some positive suggestions. She says, we need to address concerns and learn from them. We need to be supporting the workforce to deliver the best care moving forward. Delivering enhanced care to those living in care homes would be an example of this. Those older people living in care homes have complex medical comorbidities and are in the last years of life, and ensuring high-quality care in this setting is key. In Scotland, the pandemic highlighted the need to have plans in place for managing patients who had deteriorated clinically and might be approaching end of life. Advanced care planning was recommended for all older care home residents. When end-of-life care was to be delivered in the care home setting, plans could be put in place ahead of time to have available medication to manage common symptoms. Referred to as just-in-case medication, prescription of medication to relieve symptoms can be given ahead of time, in preparation for changes such as an illness such as COVID progresses, to avoid delays in contacting medical and pharmacy staff out of hours, for example. These medications include morphine or similar opiates for pain and breathlessness, midazolam for agitation, hyoscine for excessive secretions, and levothyroxine for nausea or vomiting. Trained nursing staff would then be able to administer medication when needed for symptoms without delay. During the pandemic, we managed to introduce services, tests, and vaccinations rapidly. This pace of change has not been sustained, and now the requirement is to evaluate the pros and cons of the changes and plan for the future. And she signs that statement under the declaration that she believes the facts stated are true, and she is aware that the statement will be made available on the inquiry's website.
Very good. Thank you very much indeed, Mr. Gale.
Thank you, my lord.
And I think that's the evidence for today, and we're back again tomorrow morning at 10 o'clock.
Thank you, my lord. Yes.
Good. Thank you all.